The next session is discussing the properties of nitrous oxide and what makes it such a good drug for sedating our patients. As you can see, it's quite a long list. Don't think of this as some tiresome, long-winded piece of pharmacology. It's more a comprehensive justification of why nitrous oxide is a fantastic tool for the management of dentally anxious patients and medically compromised patients as well. Often patients referred to anxiety management services say they just want put to sleep. They're requesting general anaesthetic and they think that's the best way for their treatment to be provided. Their expectations can be unrealistic, but it's crucial that the sedationist is able to relay the desirable properties of nitrous oxide to the patient. We need patients to make an informed decision about the safest way for them to achieve what's going to be best for their dentitions. To do this, we have to provide them with all the information about all the various options. If you can relay the properties detailed in the following slides to your patients, it's likely you'll end up referring quite a few less for general anaesthetic in the long term. After this, we'll touch on the properties of nitrous oxide, which mean we should limit its use to specifically where necessary for the benefit of our own health as well as the health of the planet. Our first and most important feature is that of safety. Safety is key to the practice of conscious sedation. In fact, it's integral to the definition. Take a minute to remind yourself of the definition of conscious sedation. The second sentence states that the drugs and techniques used for conscious sedation for dental treatment should carry a wide margin of safety, enough to render loss of consciousness unlikely. Nitrous oxide is one of many inhaled anaesthetic gases. It was the first, and it's also the least potent. The potency of all anaesthetic gases can be compared using a value known as MAC, which is the minimum alveolar concentration. MAC is defined as the minimum concentration of the anaesthetic in the lungs needed to prevent movement in 50% of subjects following a surgical stimulus. Let's spend a little bit of time thinking about how that experiment was undertaken in the early days of anaesthetic. First, you need a volunteer and a surgeon and an anaesthetist. The volunteer would be given slow, incrementally increasing doses of the anaesthetic gas. After each change in dose, they'd be poked with something sharp like a scalpel. At low concentrations, they'd say, "Ouch, get off me." As the concentrations increased, they'd probably moan a little bit, and then they'd just twitch. There'll come a point for that volunteer where they'll stop twitching when they're poked with the scalpel, and the anaesthetist would write down that number as the MAC for that drug for that patient. We all know different people have different sensitivities to different drugs. Take alcohol, for example. To make this a useful comparator, we have to repeat this rather unpleasant experiment for a lot of people. With all the results collated, the median value would represent the concentration at which 50% of these subjects stop twitching when poked. The MAC values for different anaesthetics can then be compared in terms of their potency. Here we have the MAC values of two different anaesthetic gases. To keep it simple, we're just talking about the two anaesthetic gases available to Sir Arthur Conan Doyle when he penned the Sherlock Holmes mysteries. One gas would allow an operation to be performed in half the population in an inspired concentration of 0.5%, whilst the other has to be turned up to over 100% to allow just half the population to tolerate being poked with something sharp. Which one is more potent? Well, it's the one that only has to be turned up to 0.5% to allow the operation to be completed for half the people. And what are these two mystery gases, I hear you ask? Well, the one with a MAC of 104% is nitrous oxide. As we know, it's the least potent. And the one with a MAC of 0.5% is chloroform, which you just need a whiff of in order for a patient to pass out. So, nitrous oxide's high MAC is a quantification of its low potency, which means it has a wide margin of safety, meaning it's unlikely to render a patient unconscious, but not impossible. Like nearly all biological parameters, the patient's sensitivity to nitrous oxide obeys the normal distribution, the classic bell curve. This means that a small number of patients will be anaesthetized at much lower concentrations than this 104% MAC. Anesthetic textbooks will tell you that successful clinical anesthesia begins at 0.5 MAC for some individuals. For nitrous oxide, 0.5 MAC is 52% nitrous oxide. At this concentration, approximately 0.1% of the population will be rendered unconscious. That means we need to be cautious in delivering our nitrous oxide and always titrate to effect, keeping in mind that definition of what conscious sedation is. Those of you thinking it's impossible for any gas to have a concentration of 104%, you're right. The MAC for nitrous oxide is calculated with a degree of high pressure conditions and also a degree of extrapolation too. The next most important feature of dentists is that nitrous oxide is an anxiolytic. It has its effects on the cerebrum, cerebrains and brainstem. And in so doing, decreases the patient's awareness of sights and sounds around them, as well as sight sensation of pain. It means the patients just aren't connected with the history that you're providing, not connected as a result with the treatment. There's no trigger for those negative cognitions that they associate. And there is no trigger for the negative cognitions which they associate with dentists through a phenomenon known as dissociation. That it has this where patients feel separated from their bodies, known as dissociation. It can go as far as entertaining and out of body experience, things like ketamine. Some people love. The effects can range from that puts it in a feeling of being slightly numb to your environment. For most patients, full-on out-of-body experience occurs between about irrespective of how the patient describes the anxiolytic effects. At this point, patients often become restless. Bear in mind that these effects are not in a linear dose-dependent relationship. Can look quite similar to most people dental anxiety. So it's really important to remember nitrous oxide between responsiveness at 25 and 40% nitrous oxide isn't a linear dose. Beyond this point, they become all about oversedated, and as a result, they become unsettled. However, a patient describes this anxiolytic, it looks quite similar to the signs of dental anxiety. And it's quite often people term it as nitrous oxide. Most of age groups they should be using for age groups. This sedated state exactly understand the mechanism, lower concentrations it has its anesthetic effects is what was originally termed as its relative analgesia, an NMDA receptor. It's a semi-hypnotic state where we can guide a patient and their thoughts and where they dissociate to. On its own, nitrous oxide provides some anxiolysis, but this hypnotic suggestibility means that we can take a patient to their happy place, which might be a beach, as we've just shown here, or just generally help them relax. And that requires a constant rapport and psychological support being delivered in an appropriate way by the sedation team. Despite substantial investigation, the exact molecular methods by which nitrous oxide achieves its anaesthetic properties aren't fully understood, but it's thought to be related to NMDA receptor antagonism. What we do know about nitrous oxide is that it promotes the endogenous opiate release and also potentiates the endorphin effect at these opiate receptors. These pathways produce anti-nociceptive responses, which means that dental treatment is more comfortable for patients with nitrous oxide. They just simply feel less pain. This is a property that's exploited by midwives when they give nitrous oxide to women during labour. It's also used by paramedics and doctors in A&E, where they're providing patients with a variety of pain for a variety of causes, nitrous oxide in the acute setting. That can be for people with cardiac pain or resetting a dislocated shoulder. It can be useful sometimes to inform patients of this additional property if they have a perception that dentistry is painful. We discussed earlier the issue of hyperventilation in an acutely anxious patient if they're having a panic attack and the increased pain perception that results from this. Good patient management goes a long way to overcome it, but nitrous oxide goes even further. One of the early sensations that patients will be aware of as you're titrating their dose is of tingling in their fingers, in their toes, and sometimes around their face. And that can be used to good effect when we're providing them with dentistry. We still use local anaesthetic, but giving that local anaesthetic can be more comfortable for the patient. And also I've found that procedures that can be a bit sensitive, like having a scale and polish on some exposed dentine, actually are a lot more comfortable. We need to use local anaesthetic less when we're providing these treatments in conjunction with inhalation sedation for our anxious patients. This analgesic effect is surprisingly potent. It's been quantified that a 30% dose of nitrous oxide is comparable with between 10 and 15 milligrams of morphine. Nitrous oxide works very quickly and also wears off very quickly, which is great. By comparison, midazolam, which we use for intravenous sedation, works quickly, but it wears off very slowly. This means that patients have to hang around in the surgery being monitored for at least an hour after the last increment of the midazolam that we give them. Whilst with inhalation sedation, a patient can leave the surgery 5 minutes after we've finished providing our treatment, providing they meet our discharge criteria. And patients love that because they don't like hanging around in the dental surgery. The reason for this rapid induction and rapid recovery from sedation is due to the drug's solubility. We express solubility of any anaesthetic gas in terms of its blood-gas partition coefficient. A drug with a high blood-gas partition coefficient is very soluble in blood. That means that lots of the drug dissolves away in the blood. We know that drugs have their effect when they're in a state of equilibrium. And so for a drug that is highly soluble, we keep on giving it to the body and the body keeps on soaking it up before it can have an effect. Nitrous oxide has a low solubility in blood. Therefore, pressure in the alveoli and in the blood quickly equilibrate. Therefore, we can have a rapid induction and a rapid recovery in 3 to 5 minutes. And I find that most obvious in the recovery and explaining that, in that nitrous oxide just doesn't like being in blood. And so when you stop giving it, it wants to rush out the body as fast as it can, which has the positive effects of it wears off rapidly. However, it can also give a couple of potentially negative consequences. The first of these, there's the potentially harmful condition known as diffusion hypoxia. This could theoretically occur if we're giving a patient more than 50% nitrous oxide, and then we simply terminate this treatment and this sedation by removing the nasal hood and letting them breathe room air. Due to its low solubility, the nitrous oxide would rush out of their body into their alveoli, displacing the oxygen there, which the patient would only be getting at 21%. This potentially could mean the patient could collapse due to hypoxia, and it's combined with the dilution of carbon dioxide that would also suffer, resulting in hypercapnia, which would then decrease their respiratory drive and worsen the problem. Diffusion hypoxia is very, very rare in inhalation sedation and dentistry, and that's because we provide patients with 100% oxygen for at least 2 minutes, and some sources say 5 minutes, after treatment is completed. It's also very rare that we give patients more than 50% nitrous oxide, which helps minimise this issue. The other potential complications that can arise from nitrous oxide's low solubility in blood form a small but very significant series of contraindications for the use of inhalation sedation. Some patients have air or gas-filled cavities within their body, either pathological or iatrogenic, such as pneumothorax, emphysema, bowel obstruction, or issues with their middle ear. Nitrous oxide is always keen to diffuse out of solution because it has low solubility, and given any opportunity, it will try to escape into a gaseous cavity. So if we gave a patient with a pneumothorax or a middle ear problem nitrous oxide, then it would diffuse out their blood and dramatically increase the volume or pressure inside these cavities, which would cause real problems. Similarly, certain eye surgeries leave a gaseous inclusion within the eye for a number of weeks after the surgery, and as you can imagine, dramatically increasing the pressure in someone's eye is not a good idea. In the patient assessment section, we talked about certain features of someone's medical history which you should ask them about in a sedation assessment and feed into the ASA classification. Medical history questionnaires that you're using may not specifically identify those issues I've just talked about in terms of emphysema, pneumothorax, or recent eye surgery. So keep these contraindications in mind, because the patients can be otherwise fairly healthy looking. So moving on, nitrous oxide is easily titrated. Titration in medicine means the stepwise adjustment of a dose of a drug until the desired level of effect is reached. Because of the rapidity of onset of nitrous oxide, we can judge whether a change in dose has had its effect within 30 seconds or so. Titration is essential for safe sedation to ensure the patient receives the correct dose of that drug for them on that particular day. When we discussed MAC, I mentioned the biologic variation of sensitivity of individuals to each and every drug, which obeys the normal distribution. If we were to just give all our patients the same set concentration of nitrous oxide, chances are it would be too little for a lot of them or too much for a lot of them, resulting in unsuccessful outcomes. Titration isn't possible for oral sedation or intranasal sedation, which means that as sedationists we try and avoid them where we can in favour of something titratable. Intravenous sedation using midazolam is titratable, but only in one direction. For nitrous oxide, if we think we've given the patient a little bit too much sedation because they're feeling a little bit unwell or they're generally less cooperative, we can just reduce the dose by turning down the mixture control dial. With IV sedation, we don't have this option. We can increase the level of sedation, but if we want to decrease it, then we're talking about using the reversal agent. Titration is about constantly monitoring a patient, keeping in mind the definition of conscious sedation, as well as what features of a sedated patient we should be observant for, which we'll talk about in a later session. It's not uncommon when assessing a patient who's previously had nitrous oxide, possibly during childbirth in the form of Entonox, to say it wasn't effective for them. It's helpful to explain to the patient that they would have received a set dosage of 50%, which is not the most appropriate dose for many patients. So it's worth taking the time to explain how, through titrating the dose of the patient, you can achieve better anxiolytic effect and better analgesic effect than they previously experienced. Another fantastic feature of nitrous oxide used in inhalation sedation is its flexible duration of action. That means it's as easily suited to a quick deciduous extraction as it is to multiple molar endodontics. Once we stop giving the nitrous oxide, the patient is unaffected by the drug once it's out of their system and once we've taken into account diffusion hypoxia, which means the patient's safe to leave 5 minutes after we make this decision. By comparison, when treating a patient with intravenous sedation, we have this set 40-minute or so time period of which to provide all the treatment before the patient loses the anxiolytic effect and they're unable to tolerate any more treatment. So we could use nitrous oxide for well over an hour if we wanted to, or we could use it for just a couple of minutes and for taking some impressions of a patient with a hyperactive gag reflex. Equally well suited to both of those, whilst intravenous sedation with midazolam would clearly be very poorly suited to both. With all these positive features, it would be no good if nitrous oxide had some ghastly side effects to the patient when we were administering to them. Whilst it does have some effects in chronic overexposure, for an individual patient, the other effects are minimal. It doesn't have much effect on their cardiovascular system in the doses that we're using and for the duration we're using. The one thing that does happen is patients get cutaneous vasodilatation, which they feel as that sensation of warmth when they're appropriately sedated. It's also potentially something we could use to our advantage if we're looking to provide intravenous sedation and we're needing the depth of intravenous sedation provides for a patient who is acutely needle phobic. And so what sedationists occasionally do is they will use inhalation sedation to allow a patient to be less anxious about cannulation. It also makes the cannulation easier because their blood vessels are that bit bigger. Place the cannula, stop the nitrous oxide sedation, get the patient recovered, and then with the cannula in place they can go ahead and have the increments of midazolam. Nitrous oxide is a nice gas. It apparently smells sweet to some people, and importantly it doesn't irritate airways, and that's unlike some of the other anaesthetic gases which means it's fine for asthmatics. Also, it's not metabolized to any significant extent anywhere in the body, particularly useful in comparison to some of the benzodiazepines which have active secondary metabolites, and so they have hard to predict and lengthy recovery periods and sedative effects. It also means it's suitable for patients who have compromised liver or kidney function, and its metabolism, its duration of effect, its severity of effect won't be affected by these conditions. Obviously keep in mind your ASA classification and whether the patient you're treating is suitable to your level of experience and a setting that you're working in if they do have liver or kidney disease. So does nitrous oxide have interactions with any other drugs? Well, first and foremost, we want to avoid giving nitrous oxide in combination with any other sedative drugs, as the effects of these can overlay. This will confuse your titration and potentially put the patient into that risky position of them losing their reflexes, and so out with that definition of conscious sedation. Such examples include some of the tranquilizer drugs that are used to treat florid mental health conditions, or some patients who are having medication for anxiety can have sedative properties too. Also, patients should be informed to abstain from recreational drugs before their sedation, as these will dramatically decrease the predictability of their sedation and so the safety of it. If you look up the interactions of nitrous oxide in the BNF, there are 229 other drugs listed. That's a lot to remember. However, all bar one have the potential combination side effects of CNS depression or of enhancing hypotension. The one exception, and the only one listed as a severe interaction, is the combination of nitrous oxide with methotrexate. It says nitrous oxide potentially increases methotrexate toxicity and manufacturers advise avoid. Methotrexate isn't a very nice drug at all. It's an anti-metabolite drug. It's commonly used in the treatment of rheumatoid conditions like arthritis, psoriasis, Crohn's disease, as well as being used in a number of chemotherapy regimes. Its effect against cancer comes from the fact it inhibits cells metabolizing folate, and so makes DNA replication impossible, and so cell division impossible too. Methotrexate also impairs neural growth by blocking the enzyme methionine synthase. Unfortunately, nitrous oxide also blocks the effects of the enzyme methionine synthase by irreversibly impacting on the essential cofactor that is vitamin B12. The failure of methionine synthase can lead to permanent neurological injury. So should we avoid giving nitrous oxide to an adult who's medicated with methotrexate for a rheumatoid condition? Well, there simply isn't any evidence in the concentrations of methotrexate these patients would receive and the concentrations and durations of nitrous oxide that we'd be providing to our patients using inhalation sedation. There are, however, recent case reports of children who are being treated for leukemia and methotrexate being part of their chemotherapy treatment, who also had general anaesthetics using nitrous oxide for medical procedures. And a number of these children have experienced significant neurological issues afterwards. Given the consequences of the combination of methotrexate and nitrous oxide are potentially severe, it suggests it's worth avoiding the combination until better evidence is available.